হ্যালো হ্যালো, শোনা যাচ্ছে?
হ্যাঁ স্যার, শোনা যাচ্ছে স্যার।
আমি এটা দিয়ে চেষ্টা করছি। হ্যালো হ্যালো, সৌম, হ্যালো
Yes,
হ্যালো।
sir. Yes, sir. Yes, sir. We can hear you.
Sir, am I audible, sir? Am I audible?
Yes.
You are audible to me over the phone, but not over the laptop. Can you see me over the laptop?
Yeah, sir. You are visible, sir.
But I cannot hear you or talk to you over the. Okay, you know what? Give me a second. I think I know the reason.
Sure, sir, sure.
Hello?
Yes, sir.
Hello? Check. 1, 2, 3. Can you hear me now?
Yes, sir.
Hello? Tomo, can you hear me?
Yes.
Can you hear me? Hello? Can you hear me?
Yes, sir.
Hi. Hello? How about now? Can you hear me?
Yes, sir. Yes, sir.
Okay, thank you. All right. Perfect.
Very good evening, everyone. On behalf of IAP technical team, I, Dr. Jaspreet, welcome you all. I would like to welcome our today's speaker, Dr. Sanjay Sarkar sir. Sir, welcome you. And our today's moderator is Dr. Soumya Bhattacharya. Sir, we welcome you to sir. He is Secretary IAP
Thank
Tirupati
you.
State Branch. Sir, I request you to please moderate this session. Thank you.
Okay. Shall I start right now?
Yes, sir.
Okay. Thank you. Good evening, everyone. Myself, Dr. Soumya Bhattacharya, Secretary, Tripura IAP Branch. Welcome to you all in our 10th webinar being organized by Tripura IAP Branch. Today, the topic of webinar is pathogenesis of TMJ dysfunction and management. So it is the most uncovered and very critical topic of discussion in field of physiotherapy, I believe. Today it's my honor and privilege to introduce a very energetic and dynamic personality, Dr. Sanjay Sarkar sir, as a resource person for today's webinar. As a brief, introduction about today's resource person. He is the EC member of IIP West Bengal branch. He is the first MPD degree holder from West Bengal, and passed from NIH Kolkata. He then went to USA to complete MS and PhD through United States government scholarship. He was taught osteopathy by none other than father of modern osteopathy, the late Dr. Philip Greenman. He was an assistant professor at Concordia University and visiting professor at Minnesota State University, USA. He is the director of Minnesota Gerontological Society, member of American Physical Therapy Association, a member of American Society of Biomechanics. He was a research scientist for Mayo Clinic, the world's best hospital for past 18 years. Now he is back with us conducting workshops on osteopathy and has 2 osteopathy clinics in Kolkata. I welcome you, sir. Sir, are you listening?
Yes, I can hear you. Yes. I'm taking over then, Dr. Bhattacharya. All right.
Yes, sir. I'm handing over to you, sir.
All right. Perfect. Thank you.
And one request to attendees during that session, if you have any doubts and questions, please write it in the chat box. At the end of session, I will pass the questions to our respected resource person. Thank you. Thank you.
Thank you very much, Dr. Bhattacharya. First, I would like to take this, moment to thank all of you participants who are attending either through Zoom or through YouTube Live. It is a privilege for me to come and talk to you again, obviously through the webinar itself, so very virtual. The other thing that I would like to share is I am really grateful to the IIP Tripura State Branch for inviting me and asking me to talk about any topic. And Dr. Bhattacharya and some other of his colleagues wanted me to talk on TMJ, TMD, whatever. So this is my presentation. And then I would also want to thank the Central IIP, Dr. Sanjeev Jha, Dr. Ruchi Varshini, Dr. Annamalai Sir, and Dr. Joji Jones for providing the platform to reach to you guys and to, not only just you who are participating, but pan India, maybe all over the world, especially during this time where we are, are apprehensive about going out and treating patients or, enjoying the environment or the weather with our family. Just a brief overview before we dive deep in. It's a 1.5 hour webinar, right? And TMJ welcomed me. In fact, when I was working in US, one of my colleagues' friend who was working in a hospital in Minneapolis, Minnesota, she actually provided me the first hands-on approach as to what TMJ dysfunction means. She just works on TMJ, maybe some about sinusitis, migraine, headaches and other kind of stuff that is only related to the face and skull. She is obviously a PT, but she only works, her clientele, her patients are only focusing on the skull bones and the facial structure. Anything and everything related to this part of the head essentially is the only thing that she was working in. And I was really curious as to, how come are you doing this? Like, I have never seen nor heard at that time, which was like, I don't know, 10 years back already. Time flies, as we all know. And then she told me that these are the nuances that you can actually create a niche. Niche means a very specialized focus of your private practice. When you let's say if you are a student, then after you graduate or who are already professionals, you can actually ask your dentist friends, colleagues, family, whoever is a dental surgeon. They have lots and lots of patients coming in with TMJ issues, and unfortunately they don't have the experience or expertise other than obviously medication to essentially not quote unquote, not cure, but ameliorate or reduce the problems of motion and pain in the jaw area. We all know TMJ, obviously it will lead to locked jaw, so the patient will not able to eat. And it's not right, it's not wrong. You guys are right in thinking that way. But the thing is, it's not just that. There is far beyond problems and pathologies and pathogenesis, that is today's topic, that can lead to TMJ issues. So today, what I am going to do is, hopefully by the end of the hour's webinar, you'll be able to interpret a foundational knowledge of anatomy, biomechanics, and a little bit of assessment and evaluation in your clinical setting. I also want you to know how you can compare and contrast a little bit about structural differences, meaning, is it muscular origin, or is it joint origin, or are there anything else that is associated with this kind of a problem? So we are going to touch very briefly on these topics. And then lastly, distinguish different pain causations, describe different diagnostic patterns, again, very briefly, and understand treatment measures. I know you guys are probably like wanting to know about treatment, but obviously through a webinar, ethically, I am supposed to not show any treatment per se, but certainly since it's a webinar where there on the topic itself, it does mention treatment. I'll give you a very basic overview, a brief idea on what type of treatments that people generally follow in terms of protocols that we do. So what to expect today? Essentially, this is basically, the lecture, how it will flow through the next hour or so. When you open the book, when you read the contents page, right? And you know, oh, this is the first chapter. This is the second chapter. And inside the second chapter, you have these other things. So this is what to expect today is nothing but contents of today's webinar or lecture. I always start with a picture because picture speaks a million words, right? You all believe in that. Picture speaks a million words. And these are the two commonest areas where your patient or your client with TMJ issues or with issues with the jaw pain have, will point it out. So the very first thing, since as Dr. Bhattacharjee said earlier, my first initiation in osteopathy was through Dr. Philip Greenman. Unfortunately, he's no more with us. But in 2009, when I heard a lecture in one of the conferences close to Los Angeles, my mind was blown out. I had no idea that my hands could do so much of a miracle to patients. And in fact, I am right now sitting in the clinic. Last evening, a patient came with a migraine pain. And today she called me in the morning and was crying. It's not that I did something magic, because my philosophy as a research scientist with like close to 12 years, I've been doing research with big universities in the world. I believe in science. I believe in evidence. So nothing is miracle for me. Nothing is magic for me. It has to follow certain guidelines. It has to flow. It has to have a direction from point A to point B. Like for Ganga, it obviously starts in the Himalayas and ends in Bay of Bengal. So it always has a direction. So my philosophy is based on evidence. And when I'm talking about evidence, the most commonest symptom or the pain pattern that the patient will tell you is, oh, I have pain over here. Right underneath the mandible, inside the mandible, they will point and say, that is extremely painful when I am, chewing, biting, anything that requires jaw motion. And the other commonest area obviously is nothing where your TM joint is. That's basically the picture on your right bottom, which this lady is pointing at. Now, important for me, whenever I show a slide, a content, it has to have a meaning. Even just these random pictures, they are never random. Nothing should be random when you are talking about diagnosis and treatment. It has to follow justice and protocol. So in this case, as you can notice, TMJ symptoms, meaning patient probably, if it's a long-standing case, after dental damage. So a patient went and fixed the crown of the tooth, or did a tooth extraction, he or she probably will have some amount of jaw motion anomalies. And here I would take a moment to say that we as a PT are movement scientists. Everything that we see in a patient is dysfunction in the motion, aberration in the motion, how the movement changes is taking place throughout the body. Even though when a patient comes to me with jaw problem or jaw pain, I always make it a point to make her walk. I always see her 4 rounds, usually 3 or 4 rounds, and see holistically as to where the problem lies, and accordingly I will try to fix it. Okay, so dental damage or dentist, any problem with the dentistry has a huge repercussion or sequelae in TMJ issues. Similar to migraines, they can radiate, migraines can radiate to TMJ issues. TMJ issues can radiate up towards the temporalis muscle and cause migraines, okay? Ear pain, anything that leads to internal ear infection, they could lead to problems in the TMJ because you have eustachian tube or eustachian canal that connects your ear with your throat, and that's the passage for the infection, creating pain and dysfunction of your TMJ. Then you certainly will have jaw pain when you are speaking, when you are biting, when you are chewing, when you are doing anything, speaking, talking, whatever, whatnot. Even sometimes sipping, sometimes if it is that severe, just sipping some liquid can also be painful. And then I always check C1 and C2. I'll repeat this for you. Oh, when I take a webinar, and this is not the first time I'm doing a webinar. Webinars are extremely common in US, and every summer I do radiology courses, and I do a hybrid course through webinars and obviously in class or in campus style. So probably I've been doing webinars, I don't know, maybe 6 to 8 years. It could vary that much. So you have to have a pen and a paper if you have to follow me. I do not, and I repeat, I do not read through slides. I'll tell you a story which will help you understand the pathology and the pathomechanics and ultimately diagnose and treat. So what you are going to listen to me, and if you are following the PowerPoint, it will be a story where I will touch upon those bullet points. If some of the bullet points are easy peasy to understand, meaning simple, then I will not going to touch upon those. It's your duty to go over that. Now, when I'm saying your duty, you don't probably have that, right? Not by magic, at least. So if you're interested in, having this PowerPoint, at the end of the PowerPoint session, I do have contact information. Get in touch with me and I'll share the PowerPoint with you. So that's how easy it is. But obviously certain conditions apply. And then if you are asking for the PowerPoint, I'll let you know those things. Okay, without further ado, so this is essentially the theme that we'll go through or follow during the slide presentation. Did you know, I always love, what people think, that's the myth, and what reality check is. Okay, so people think that chewing too much or eating hard foods like candies or like meat, anything meat, can cause TMJ problem. Now that's actually the misconception that people probably have, that just by biting or chewing hard foods or chewing gum, bubble gum, that should not cause TMJ issues. At least there is no evidence to suggest that. And then if your jaw hurts, keep it closed. Never keep it your jaw completely closed, because that is not the open pack position of the joint. And all of you, I'm sure, there should be about 240 or 200 or 340, 350 odd participants right now. So essentially you should all know that open pack is where you want the joint to be, so that it is completely relaxed, right? You want the soft tissue structures, the joints, the cartilage, and the contractile elements to be as relaxed as possible. So never ask your patient who has TMJ to always keep their mouth closed and teeth clenched. Never. No, it's a no. They should actually keep it partially open to have a relaxation of the muscles. And how is the other thing, no cure for TMJ. And this actually happened very recently, and now recently, even actually just before the lockdown, so about 2.5 months previous, I had a patient whose son is a dentist, and she came to me with lockjaw or TMJ issues, and fortunately it got fixed in 2 weeks or so. Then the dentist actually came to me and said that, how is this even possible? He did not know. So I told him, these are the techniques that you can use. Theoretically, that should actually take care of the movement dysfunctions. And when you take care of movement dysfunction, the pain should also reduce, if not go away. Now, I said movement dysfunction first, pain second, because my belief is you cannot probably control pain, because pain is abstract, pain is subjective. My pain and your pain will be different because our thresholds of understanding, feeling, perceiving pain is different. So in reality, what we are trying to quantify is basically motion, right? Motion is what we are trying to quantify, and that actually helps us get to from point A to point B. Okay, with that thought in mind, now reality is jaw motion is good. Now, if it is a very, very acute or long-standing chronic, maybe the jaw motion could be aberrant, but usually if it's a pretty, just subacute to chronic stage of pain or, pathology of the TMJ, then jaw motion is usually good, and there is not much aberration or motion dysfunction in the jaw. Fact two, obviously you have to stretch muscles, because we all know through myofascial release, through active release techniques, through neurokinetic therapy from Dr. David Weinstock, we all know it is very, very important to release inhibited muscle and to activate also, to release, hypertonic muscle and to activate, inhibited muscle. So those are the things that you need to take care of. Dental procedures can certainly lead to TMJ. In fact, I do have a patient currently who actually have not seen, so she will be coming hopefully next week. She is a young kiddo, right, about 14 or 15, who she actually had those dental clips in place and started to have jaw problems. So I am guessing that dental procedure probably led to jaw motion aberration or dysfunction, leading to some very mild discomfort or pain in the TM joint. Grinding, yes, that is extremely important. In fact, I was talking to one of my colleagues, again, a PT here in town, and he was also saying that, yes, he did find that grinding leads, obviously, as you can see. So doing this constantly, not just consciously, but subconsciously, when probably your patient is sleeping, during sleep also, you have seen or you have heard or, somewhere that, you grind your teeth, especially with blocked nose or sinusitis, you tend to grind more, and that could lead to, again, jaw motion. That friend of mine I was just talking, who's a PT, he was saying that we have this in US, but I was not sure if we have it in India, but he said, yes, we do have some jaw separators like gel pack, which we can use it to keep the jaw as relaxed as possible during sleep or during night. Okay. All right. This is one of a very cool picture of the skull. But the thing is that you probably will not be able to see or, today discuss the arrows. These arrows are extremely important, meaning these arrows represent vectors. As you can see, read it, complex vectors. I'll give a moment because the internet probably is not that good. Okay, now, what I was saying is these red arrows are vectors. These vectors has length and has some dimension, if you remember from basic physics 11 and 12. By the way, since I'm a biomedical engineer, that's what my PhD is in, and you can search it online by my name, you will know that I love physics. I love the understanding how vectors work in soft tissue. So this is extremely important. The length of the vectors, the direction of the vectors give me an indication of moment arm. Moment is essentially coming from momentum, mass times velocity. So that faster you move your jaw, the higher the grinding takes place, the higher the compression of the TMJ takes place. As a result, the pain will increase because there is sequelae of event, adverse reactions or event that will follow. So because of the constraints of today's webinar, an hour and a half, I'm not going to discuss about the vectors and the theory of how the vectors are so much variable. But let's talk about what it does, what these muscles does. Obviously, chewing, anatomy. Those are the things that probably takes place or plays a huge impact in TMJ dysfunction. All right, this is a very cool slide. Now, if you are noting down, you have a pen and paper, there are primarily 4, secondarily maybe 1 muscle which is completely associated with TMJ problem. As you can note, this temporalis muscle, masseter muscle, you have internal pterygoid and you have external pterygoid. Internal is sometimes called medial pterygoid, external is sometimes called lateral pterygoids. So 2 pterygoid muscles, temporalis muscle and the masseter muscle. These are the 4 muscles of extreme importance with TMJ. The 4th one is your belly of the digastric, the muscle that is the base of your buccal cavity, that you can palpate right over here, can also be spasmodic. As a result, that can also, after spasm, it can pull the jaw down further and create more pain while eating. So that's digastric. I talked about 5 muscles: temporalis, masseter, 2 pterygoids, and the lastly is digastric. So these are my contractile structures. Again, I don't want to digress too much because I can talk and eat your brains apart. And some of you actually, Dr. Bhattacharjee knows me that well. So unfortunately, we don't have time today to talk for me, right? And you want me to show you stuff. All right, so the thing that is important is this sphenomandibular ligament. Unfortunately, ligament falls under non-contractile tissue, and non-contractile tissue, you cannot change, but you certainly can change. There is a law in physics, again physics, called creep, C-R-E-E-P. With the help of creep mechanism, you can change the mechanics of ligaments, and that's what I do from my school of osteopathy taught by the original Dr. Philip Greenman. I did not do his course, he already passed away, but I follow his thought process, essentially the philosophy that he taught. So I will show you a little bit of how we can manipulate the creep factor and try to induce certain changes in the non-contractile unit, that is the sphenomandibular ligament. We talked about muscles of mastication. So masseter, you do bite, the masseter pulls. You bite, the temporalis pulls up. The temporalis, the anterior part of the temporalis, right over here. These fibers actually sometimes pull the jaw more outside or protrude the jaw. They also try to protrude the jaw. When you protrude and bite, the anterior portion of the temporalis actually plays a huge role in kind of pulling that part of the jaw. You have the pterygoids, the medial one. You have the lateral pterygoids, or the there are superior and inferior heads. I'm not going into it. You just mentioned lateral pterygoids, which is essentially the external pterygoids, and the belly of the digastric. All right. This is now kind of, we are jumping from a basics anatomy, a little bit of vectors, that's biomechanics, very, very little. There are a lot of things that we can talk about. Now we are into, the examination portion. Interincisional distance, or incisal, that is from the teeth called incisor, right? This teeth is incisor. So from the incisor distance, what we can measure, if the jaw, or not, sorry, if the mouth opening is less than 1.6 inches, which essentially means 2.5 or less than this, then there is a problem in the TMJ. Mention it, write it down. If it is less than the jaw opening, mouth opening, gob opening is less than 1.4 inches, so essentially 2.5 fingers, and if it is less than that, then there is a jaw issue. This is a very quantified way of understanding if there is presence or absence of TMJ issues. Temporalis examination. All right, for temporalis examination, essentially you need to palpate the temporalis muscle, and then there are, you don't have to go through anterior, middle, and posterior region just to palpate those muscles, but it is easier for you to, palpate the muscles while the patient is kind of biting, to help in the contraction, to feel the contraction of those musculature. So right now, I'm actually going to show you how to examine temporalis muscle and thereby help in, to understand the function of it better. So give me a second, please. All right, I hope you can actually see me working on, I'll remove the glasses. All right, it is best actually to sit more superior, to sit a little bit superior so that it is easy for you to palpate. Now I will tell my patient to do a little bit of opening and closing to palpate around the temporalis bone or temporal bone for the temporalis muscle. So open and close your jaw, bite slowly. So about 2 or 3 repetitions will help me understand the balance of the temporalis muscle, and if the temporalis is painful, if there is tenderness, if there is point tenderness or not. I can easily figure that out by palpating. Obviously, by the temporalis there is throbbing of the blood vessels. So just by palpating around the throbbing of the blood vessels, you can easily palpate the belly of the temporalis muscle. Then that's how basically you do it. Now comes masseter. For masseter, I'll be actually looking towards the face, So I'll be standing right over here. And then I will ask the client to actually again palpate where the masseter is. Masseter is right along the angle of the jaw, but you should not be palpating right at the angle of the jaw, but a little bit into the jaw right over here, and then start opening and closing the mouth ever so slightly, very slightly, open and close. Again, 2 or 3 repetitions simultaneously with both hands. That's it. Simultaneously with both hands will help me understand the muscular function, the motor control of the masseter muscles, if there is any point tenderness or not. So those are the things that I'm looking at, and also if it is inhibited or if it is hypertonic, it also helps me understand that piece too. All right, for pterygoid examination, for lateral pterygoid, again, right now that you have 2 pterygoids, but it is extremely difficult because one of the superior head of the lateral pterygoid is very high up close to the skull. So it is impossible to palpate. So we are essentially, trying to palpate the normal pterygoid as a whole to help you understand how the function is. And for this, as you can see in the picture, to palpate lateral pterygoid, protrude. Exactly. So probably for this client, that lateral pterygoids are not working, or maybe it is difficult for the function of the pterygoids for him to protrude the jaw. It is essentially protraction of the jaw. This is the function of lateral pterygoid. For medial pterygoid, you have to palpate it with the help of biting it. Now, when you are biting, you use those in sticks. Obviously, you don't put your finger, but for the sake of understanding, my finger will be that ice cream stick. Hope he doesn't chop my finger off. So bite my finger. There you go. By biting the finger on either side, I am trying to feel the contraction strength. And another way of actually palpating medial pterygoid, which is not, not shown in books, but I have taken it from during my osteopathy course, is right now I am taking my pinky, my whatever finger, the last little fifth finger that you talk, put it on the lateral part of the jaw, right outside. So it's on the inside of the jaw, but outside the teeth. Inside the jaw, but outside the teeth. And then palpate around the jaw area inside, where you hit the bone, where you hit the jawbone. That's where your medial pterygoid is. That's how I like to palpate, because that's how I was taught. And then I kind of go in and then kind of palpate round like this, and ask the patient to kind of do a slowly, give another, whatever, like a ice cream stick, and ask him to bite. By biting, I actually feel the contraction of the medial pterygoid by that way. Okay, all right, next. Now, my favorite, palpation. Okay. All right, so the muscle testing that I showed you, I don't do it the first thing. I always check for motion, then I do palpation, and which you all probably have learned in your physical therapy or physiotherapy coursework, right? So what I tell my patient when he or she comes is, if they have jaw problem, he does not have any jaw issues as of now. So obviously it will be very normal for him to open and close. But let's say if somebody has any problems, this is how I would like to test. I like to ask him that please open and close your mouth 3 or 4 times, open and close. When he's opening and closing the mouth, what I'm trying to focus, see if the jaw with the teeth, 2 teeth are aligned in the midline or not. Extremely important to know. They should be aligned, and the lower jaw should open and close. Open and close based on the midline. So if the jaw, let's say this is obviously the midline, and I am trying to visualize like half the mirror image. If both the mirror images are equal, there is not much of movement dysfunction. Okay, so I am trying to check motion, if there is any aberration or dysfunctional motion is present, or I'm trying to even listen if there are any kind of noise, cracking, grinding, any popping, even popping, because if there is disc issues, obviously it's a synovial joint. How do you call it? Synovial joint. So in the synovial joint, you will have probably disc issues. So if there is disc issues, there will be popping. So yeah, open mouth, open and close. That's how I will tell him. That's the first step. Okay. Next, let's actually talk about palpation. The same opening and closure of the mouth, I will actually palpate right on the TMJ junction or the joint itself, right over here. Palpate with 2 fingers. It's always a 2-finger palpation. Never palpate with 1 finger. Why? Because you are not only palpating the joint, but you are actually palpating 2 ends of the joint, anterior end and the posterior end. The condyle of the jaw is actually in the middle. You are trying to feel the translation. You are trying to feel the rotation of the jaw or the jaw of the TMJ, the mandible, that portion during opening and closure. So open and close, please, couple times, 2 or 3. I actually feel there is clicking on his left TMJ. So his left TMJ, the mandible, the mandibular part is actually jutting out when he is trying to open. So obviously he doesn't have any sign and symptom, but I would actually like to adjust his left TMJ, because when he is doing this, opening the jaw, the condyle over here is moving laterally, which makes me feel that probably one of the muscles is tighter or is inhibited, which is causing this dysfunction, because he doesn't have any dysfunction when he is moving or opening and closing the jaw. Okay. All right. Again, you have questions, write down and give Dr. Bhattacharjee at the end of the webinar. I would love to discuss those. Listen and feel. As I said, crepitation, popping. So listen and feel together, all these three things. Deviations. Now, deviations means if when the patient opens, so when he opens and he's trying to mimic that the jaw, lower jaw is actually deviating to the right. If there is problem on the right side, only one TMJ is painful and the jaw is moving to that painful side, it is probably the medial pterygoid that's a problem. Either it could be sore, either it could be hypertonic. So it is kind of pulling the muscle toward the same side of the pain. On the contrary, if the pain is on the right TMJ and his deviation is on the left side, so if he's trying to deviate like this, that is the contralateral side. That means the lateral pterygoid is actually laxed, loose, atrophied. It is not playing the proper role. As a result, the jaw is shifting more laterally, and that is the problem area if the pain is on the right side. Lastly, and probably the most commonest that you will find is disc derangement. And how do you know there is disc derangement? Disc is involved, and about 80 to 85% of the time disc will be involved in some form or the other. But how you know for sure? Deviation during opening, then returning to midline. Meaning, look at me carefully. So I opened in midline, I ended in midline, but in the middle it was shifting to right and left. So from center, moved to left, and again came back to the center. So any deviations of that when it comes back to the midline or center has probably disc issues. Again, in healthcare system, there is always variability. Take it with a grain of salt. Not every patient, 100% of the patient having this kind of motion will have these problems. Neither that contralateral means only lateral pterygoid will be affected. Probably all other muscles are affected, or maybe lateral pterygoid is not affected. It could be caused from something else. You have to have an open mind. You have to have an open mind and think about possibilities. If you don't think about possibilities, your creative ideas will be diminished and you won't be able to diagnose. And those who have done my courses, you know, I am extremely strong and judgmental sometimes about diagnosis. If you cannot diagnose, you are not a good PT at the end of the day, right? I am not if I cannot diagnose any cause. I don't want to shoot an arrow in the dark and say, oh, this patient got cured because my hands are pretty nice, but the next day the same type of patient I'm not able to cure, then I'm not good at what I do. So my diagnosis needs to be perfect every single time to make me believe that I know what I am doing. Okay, all right. Clinical characteristics. So in terms of clinical characteristics, I don't want to go through it. We actually talked about it. So these are the things that you essentially go through. Differential diagnosis. Now for differential diagnosis, pain, if it's just focused here and there is no other radiations, then probably it is TMJ only. But if someone, you know that myofascial pain syndrome, trigger point, right? If fibromyalgia, pain can radiate over here through the temporalis and probably mimic TMJ, but not TMJ, then how are you going to differential diagnose? Well, check for other joints, check for the C-spine, check for the shoulder joint, check for musculature in the neck, extensors, check for other, you know, soft tissues, check for the fascia, how it is doing. And you will be able to diagnose if it's a myofascial pain syndrome, if there is motor control loss, if the issue is because of dentition. The teeth are completely, you know, up and down, that can also create that, and teeth grinding during sleeping. Okay, now, I have only 5. This does not mean that there are only 5 of these pathologies that can mimic TMJ. It is not. It is ever expanding. These 5 are the most commonest that you will come across, that you might have a little bit of a challenge differentiating between a myofascial pain or a fibromyalgia with TMJ, or issues with motor control loss in the pterygoids to TMJ. Those are the things that you would have challenge with. But again, This is not the end of the world, that what you are reading is that's a period and nothing more. There could be many other whole gamut of stuffs that can play a role into it, but these 5 are the most commonest. All right. All right, I'm giving Zoom a little time to buffer so that you are able to hear me clearly and consistently. So I know the cache memory will take time, and many of our individuals here may not have good internet. So I'm taking a little bit of time. Treatment principles. All right, this is osteopathic way of thinking through treatments. Again, osteopathic way meaning this is American osteopathic way, not the European system of osteopathy, which is a little bit different than American system of osteopathy. Now, you have to relax the soft tissues roundabout here, adjust the joint, improve the motor control of the musculature. So, patient comes to you, you evaluate it by seeing, by looking at it, objectively measuring. Then you palpate the TMJ, then you palpate the temporalis, masseter, medial pterygoid. You can either help the medial pterygoid by checking to bite or protrude for the lateral pterygoid. It is extremely difficult to find lateral pterygoids. So just be clear about that. So after that, I know for sure the individual has TMJ issues. All right, good. Then basically what I do in terms of treatment, I try to relax these muscles. And there are a variety of ways to show it to you. I will give you certain, flavors of a biryani, so to say, if biryani is TMJ, in terms of flavor as to what the treatment techniques can be. And lastly, you have to adjust the joint, and then how can you improve motor control? Motor control obviously is home exercise program. And most of you who have done the courses with me know that I like strength, but strength training is not my go-to. I ever, 100% of the time, I do not ever give strength training or, home exercise program that improves strength. I don't believe in that from the very first day. I always give motor control exercises. It's like a, dead belief for me based on Shumway Cook and Marjorie Woolacott's theory. And then I am a NK2 level NKT, Neurokinetic Therapy by David Weinstock, level 2 practitioner. I am certified with David himself, actually, which I took with him in San Diego like ages back. So what we feel, or what I think, is basically you have to improvise motor control in your home exercise program, in your exercise prescription, the very first phase. Otherwise, the pain or the ailment, the anomaly will never ever go or move away. Okay. All right. So this is, before this, let's talk about how we treat. Okay. Lay on the bed. So first thing, I'll show you how you can, the types or techniques, how you can relax muscles. The first way to relax muscles, is essentially simply pressing on the painful areas for about 60 to 90 seconds. According to Dr. Greenman, he prefers 30 to 90 seconds, but mostly 60 to 90 seconds. Hold around that area and then do it for 3 repetitions. Probably the pain will reduce by a little bit. I also do this kind of technique for temporalis and masseter. First, if it's too painful, I go along the line of the fibers. But in subsequent treatment sessions, when the patient comes back after maybe 2 or 3 sessions, then I do transversely also. And it's not, and I repeat, it is not friction. I do active release technique. Active release technique, ART, is actually a type of philosophy or concept which is much more refined than myofascial release. It comes under myofascial release, that most, I would say probably 60, maybe 70% of chiropractors in US, they do active release technique. So I do active release technique. And you can also find courses, globally they do courses. There are level 1, level 2, full body, this and that. There are a bunch of courses. That
Sorry, sir.
But
Sorry, sir,
so I do
please.
active release, and for active release, let's say if I do it for masseter.
Sir, please switch on your video, sir.
Please switch my video off. How can I switch off my video? I am showing, right?
No, you switch on your video. Your video is not showing.
It is already on.
No, sir.
That's weird. I can see myself.
Yes, sir. Video is on. Sir, you can continue.
Video is on, right?
Yes.
Okay,
yes.
okay.
Okay, all right.
Okay.
Yeah, you gave me a shock. I showed so many things right now. All right. Okay, I think we are good for now. Okay. So let's say I'll show active release technique or ART for the masseter. As I said, masseter muscle is right along the jaw line, jaw angle, and it goes up towards the mandibular area. So my focus is to palpate around this area and see in terms of ART, active release technique, what I do. So when I am pushing, I'm pressing, probably if I press too much, I hit the bone. I know that's the limit. I come up 50%. I come up 50%. So the depth where my two fingers are pushing or poking through is essentially half the thickness of the masseter muscle in this case. So right now, that's what I'm trying to feel, the thickness of the masseter, and then come up a little bit. That's where it is. Now I will tell my client active release, right? To open the jaw partially, then do a motion similar to friction soft tissue manipulation from the origin or to the insertion. Again, origin and insertion terminology is old, outdated, obsolete. There is no origin, no insertion. Both are attachment points. So one is the inferior attachment points, the other is the superior attachment point. So I am palpating or pushing the muscle from inferior attachment point to superior attachment point by making him do keeping the mouth in open pack position. That's just a start. That's basically phase one. Phase two, I will ask him to open and close the mouth 50%. And when opening, I am again stretching. When closing, I am coming back to the origin. Opening, up, closing, down. So your finger positioning or motion will be in rhythm with the opening and closing. Does that make sense? Angle of the jaw towards the orbit, eye orbit, and that's where you are actually going. So that's ART for your masseter. Obviously, I do ARTs for everything. Now, the other thing that I do is for the pterygoids, I will show you. So now I will client to actually open out, insert the pinky, the little finger, inside the jaw, but outside the teeth, and then hit the bone back over here, the bone that is back. So what I'm trying to do is release the medial pterygoid. I'll just wait for a little bit for the internet to buffer. So release the pterygoid. So what I'm trying to do is this. This is the first phase of releasing medial pterygoid. There are again advanced phase that I cannot show you on a webinar. You have to basically do it yourself. So that's one way of releasing. So what I am doing is inside the cheek, outside the teeth. The tip of my pinky is hitting the jawbone, angle of the mandible, and doing an arc of motion. When you feel that the pain is subsiding, you can actually push the cheek and the bone behind right over here a little bit. By that, you are actually stretching the medial pterygoid, and by stretching, you relieve the pressure, the stress on the medial pterygoid. That's one way of doing it. There is another way I'll show you. Again, since unfortunately it's inside the mouth, I cannot put the laptop inside the mouth and show it to you guys, right? So I am trying to explain and go with the flow. So the other technique that I do is also on the outside. outside, right over here, probably you can see a little bit right over here, just at the base of the tongue. I place my finger at the base of the tongue, between the tongue and the teeth, that space, right over here, that's where the belly of the digastric is. So while I'm doing that, I press on the digastric and ask him to swallow. So with that, the contraction of the digastric, I am able to rhythmically control with the swelling, pressing, with the swallow, press the belly of the digastric. By that, you are able to again use the digastric to contract more, to build more strength, and then help to relieve spasm in the digastric if there is any. All right. Now it comes. As I said, I have still there. So if there are, point tenderness, trigger points. So I use this. This is again a percussion hammer gun. I got it from US, called Hypervolt Hyperice. So I use this that for, like, if there is trigger point on the masseter or sometimes on the superior portion of the temporalis, not just by the rim of the orbit, then it will be too painful, and sometimes you can cause injury to the temporal pulse. Hope you can see the vibration, right? It is not a vibration instrument. It is not. It's a percussion hammer gun. There is like a hammer drill. There is a hammer within this that kind of does tuck, 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 tuck. So it pushes the nozzle in front. So this is what I am trying to do on the masseter. If the angle of the jaw is painful, I'll place it right over here and, rotate it where you have pain, probably about 30 seconds, leave it, 10 seconds of relaxation time, and again 30 seconds. By doing that, I can easily relax muscles which has point tenderness, trigger points, maybe a little bit of fibromyalgia involved in that. So it can break the adhesions, break the scar tissue, break all those fibrous formation when it is in chronic state that is difficult for the patient to open and close the jaw. I can easily break with this instrument. Next. First, how I adjust the joint. There are multiple ways of adjusting, but the very first thing that I do to adjust is use an adjuster. So this again is, I got it from US. You can get a knockoff thing from made in China, but I don't think it's worth it. You will be wasting more money than you'll get anything in result. But if you get the original one from US, go ahead. I can change. There are many markings like, tensions and pressures that I can change based on my feeling. And I've been doing this for so many years. I have a little bit of expertise in this. And then I try to adjust. So how I adjust is I tell my patient to open in the maximum pain-free range and then adjust. So I adjust on the TMJ depending if the protrusion of the jaw mandible is more lateral. I also place it around the angle of the jaw. Do maybe 4 or 5 hits around the angle of the jaw to move it properly. I sometimes do it in the belly of the digastric, right over here underneath, right there. That actually releases, shocks the digastric belly muscle and releases the muscle spasm with the help of the adjuster. So that's one way to adjust the joint. Second way, or actually I do this always for, as I said, I always mobilize C1 and C2 joint, because you know that when someone has TMJ, they probably will have a little bit of neck pain, and the neck pain or the TMJ are referred vice versa to C1, C2 or back, or from here to C1, C2 area. So I tend to manipulate the C1, C2 joint like this. So let's say if I try to, if the patient has pain on the right side, I'll be trying to open the jaw, C1, C2 facets on the right side. So this is how I'm trying to do. Lock the joint at the C1, C2 level. That's it. I don't know if you have heard the crack or not. It was actually audible. Obviously, it would be minute, but it is audible like a crack. So C1, C2, I do it always in patients with TMJ to help relieve spasm and any kind of scar tissue or subluxation that is present in the spine. And and there are other things also that I do is, again, I'm still trying to adjust the joint. I'll actually be behind right over here. There. Okay. Right. All right. There you go. So this is a technique I learned in US with someone who is a clinician, and he had learned it from one of his friends who was a clinician. So I don't know the efficacy of this, but this works out like fantastic. I don't think you will get to know anywhere else. It's not in the books, any book. All right. So if the pain is on the right side, I will actually rotate the head to the right side. After doing that, I'll place the palm or heel of my hand, palm of the hand or heel of the hand, just above the TMJ joint, just above the TMJ. And then do a sudden motion where I push the TMJ, the jawline, in an angle which is medial and inferior. So inferomedial. I'm doing it one more time. Heel or palm of the hand, base of the palm actually is right above the TMJ. Head is same side rotated. And this is my angle. This gives me the angle. I do a sudden this thing. I did not do it this time because I've already done once. So what I did is a slight push on the TM joint and the jawline that goes in the inferomedial direction. This many times here in India or in US, I have seen the clicking of the jaw stops by resetting the condyle in the cavity of the TMJ. This is a wonderful technique if you can master it, that will reset the TMJ by placing the mandible or the condyle of the mandible right in place on the TM joint. All right, so these are the few tips and tricks that I do for adjustment of from the bony aspect. Now, in terms of home exercise program. Oh, wait, no. So in terms of home exercise program, I always start with, you wait over here. I always start with, straw blowing, bubbles, essentially bubbles of water. That's how I start to, build strength, build control, not strength, as I said, sorry, build control of the musculature. Maybe the buccinator and a little bit of, temporalis and a little bit of masseter and a little bit of digastric or belly of the digastric by blowing. I also ask my patient to blow balloons. So that also increases strength of the global strength of the facial musculature. Then next, I tell them to bite on with 25 to 30% of strength on ice cream sticks. That the picture that you showed for testing of the medial pterygoid, right? That is contracting the medial pterygoid. So you do those, first level with the straw, blowing bubbles. Second exercise is, blowing air in a balloon. Then the second level is go up into more so like, biting or, motor control or strengthening of those muscles. Now, when it comes to motor control of the pterygoid, it's extremely difficult to do. So how I like to do is, I put my finger right in the medial pterygoid. After doing that, I ask the client to half close the mouth. After they half close the mouth, I push or apply a little bit of pressure completely posterior where you have the angle of the jaw. That's where the medial pterygoid lies. After applying pressure this direction, right over here, I ask the patient to again open and close, keeping the middle of the jaw in the midline, and that becomes tremendously challenging and difficult for patients who really have jaw problem and disc derangements in the jaw, or sorry, in the TMJ. This exercise, this is actually an exercise, and I teach this exercise with the help of a partner, because you need to have someone who does that. So they place their finger. If your one of your patient has problem, then the wife, actually I teach the wife to do it. So place the finger back in the angle of the jaw, apply pressure, then do your half motion, opening and closing, not full but half, just half, because you just want a flicker of contraction. If it's motor control, you don't want the entire thing contracting. You want a flicker of contraction so that the activation potential is all rhythmical, is all synchronous in that way. So this is one of my go-to exercises for the second level. It's not first level, second level, to help in motor control of the medial pterygoid. And the other thing that I do to improve or relieve stress of the the face, the skull, is a figure 8 strap. This is not my original creation, but I have adapted it a little bit. Obviously, the thing that I'm going to show you, you cannot do it in the initial stages. Once the pain is nearly gone and the patient is able to close the mouth without any pain, close the mouth without any pain, I try to use that figure 8 strap. That is my contraption. I said figure 8 straps. I don't think anywhere you'll see that. So I use to decompress the cervical spine to help relieve those pressure from craniosacral therapy point of view. Craniosacral is all manual, but you can also decompress the spine and change the rhythm of the cerebrospinal flow, CSF flow, essentially. And I'll show it to you. Give me a second. All right, it seems like a cervical traction unit. It probably is this. It's not giving traction, but giving distraction. And then I apply sustained pressure. To release all the musculature, long muscles, long multi-joint muscles of the back. I try to apply sustained pressure with my body weight, keeping my body weight right. With my body weight, I just pull it up, sustain it for about 60 seconds to 90 seconds. Do it 3 repetitions. Do maybe 2 or 3 sets. Do maybe 2 or 3 sets right like here, and then release it. That's one way of doing a final mobility. This is no manipulation, no high velocity. Final mobility testing and final mobility realignment of the joints, the cervical spine and the TMJ, by doing sustained stretching of multi-axial, multi-joint muscle chain based on NKT, neurokinetic therapy philosophies. So we are kind of at the end. We are at 9:10. We are supposed to end around 1 hour 15. So we are 1 hour 10. I need probably 15-20 minutes for you to ask me questions. So take home message when you go back home. And if you have questions, always ping me. So take home message is you have to understand where the muscles are, what muscles are important, where the disc is and how the disc is aligned and angulated. I didn't talk about that. We don't have time for that. How to examine the musculature, how to examine the motion aberrations or dysfunctions, all these sort of motions, and basic treatment principles. So you have to relax the muscles, you have to adjust the joint and give motor control exercises in your home exercise program. That's basically is the story in a nutshell. From we touched probably a little more than tip of the iceberg, but there obviously is more to learn. It's forever learning. I can't do anything. All right, so here is my contact information. I hope you can either write it down, take a phone and photograph it. I have a WhatsApp number. You can have me tagged in Facebook, Instagram, Twitter, whatever, whatnot. And if you want this PowerPoint, just ask me and I'll let you know what things needs to be done. I think the session is open for the audience to ask me question and answer. So I will stop the screen share right at this point for you to ask me questions. Okay. All right. Yes, Dr. Bhattacharjee, shoot.
Thank you, sir. It's very difficult, means a difficult topic to make understand, as I told earlier, but you made it very clear and easy. So I would, as we have to wind up the session, so I would like to pass the questions to you, sir. Please hold on. Sir, the first question from Rakhu Das, total duration of treatment for temporomandibular joint disorder.
Oh, fantastic question. And there is no shortcut. It is hard for me to define one answer to this. Every case is different. Every case is variable. Our treatment can be as short as 15 minutes. Our treatment can be as long as 35, maybe 40 minutes. So depending on what the problem presents, patient presents, and then how you are treating it. And since I don't have any modality other than a laser and these adjuster. And by the way, somebody said it's a Theragun. It says not a Theragun, or I'm not sure if what you call that Theragun. I don't know. Anyway, it is not. So the thing is basically it is dependent on how you perceive the pathology and how you take the steps to eliminate those pathologies step by step. I have my own philosophy. You should have your own. I can only give you guiding principles. I can give you the pillars. You have to actually play the chess. The chess can be played in n number of times, n number of ways. I cannot, help in that regard, but I play in a certain direction, and for me 15 to about 35 minutes works perfect. All right.
So the next one from Krina Savla, what should be the treatment protocol for a patient suffering from bruxism, grinding?
Sorry, what?
What should be the treatment protocol for a patient suffering
bruxism.
from?
I got it. Bruxism. So that's basically grinding is very difficult, especially if it's a subconscious or when someone is laying on the bed and starting to grind. It is virtually impossible to stop the subconscious level of grinding because it is controlled by autonomic nervous system, autonomous, right? So, but you can use those, orthotics to place within the teeth, silicone gel stuff, and that will actually reduce grinding by a lot. And if the grinding has any kind of, is coming out from sinusitis or nasal septal deviation, then certainly get those. I mean, I can straighten the nasal septum. There is an adjustment technique I can do to straighten the nasal septum. But if the nasal septum is a problem, if sinus is a problem, then you have to treat those issues to clear the grinding if there is a pathology related to grinding. All right, next.
So next question, should we use any modalities for TMJ dysfunction from Dr. Pooja Jain?
I don't know. I don't use, other than if you call a test or a modality, probably it is a modality. These are the modalities I showed you that I use. I don't use anything else. And I have been doing this for maybe over 4 years, 3 to 4 years, actually, not over 4, 3 to 4 years I've been doing this. And I've been getting good results. It may not be 100%. It is impossible if I say that all my 100% with TMJ issues have relieved, have zero pain. That is a lie. It is impossible. We are all human. But I know for sure more than probably 85 to 90% of my patients have relieved from their ailment and are improving their quality of life. That's how I would define. So yes and no to your answer. Probably you can use modality. I don't technically use modalities. I also use a little bit of laser if the pain in the NPRS scale is more than 8 on 10. I have told many of my students in the workshops that if a pain is more than 8 on 10, I don't manipulate. I don't use manual techniques because that is extremely painful. I try to reduce the pain as much as possible. By that, I use laser. That's if you call the pure modality, that's the only modality I have or I use in US or in India. Other things.
Next questions from Jaya Datta. If anyone has TMJ dysfunction, will he or she has tightness of jaw or cervical pain?
Most likely. That is extremely good question, Dr. Datta. Most likely, even if not, I still apply high velocity at C1, C2 after checking transverse ligament and alar ligament. Those are the two tests that you have to do to check for C1, C2 dysfunction. And if you are able to do it, I check those two ligaments, check the integrity of those two ligaments. If they are intact, I certainly give, even if there is no neck pain, because I have found no research, no evidence, unfortunately, till now, till date, till last night at least, I have not found that. I have found there is a connection or a correlation, not a connection, but a correlation of higher neck pain or neck dysfunction, may not be pain, my neck dysfunction to TMJ. Other questions?
Next question from Dr. Natasha Mehta. Sometimes we hear the crack on TMJ joint, particularly while eating. So which technique we can use to treat that?
There is no one technique, and it is highly unlikely that one technique will be a be-all, end-all, cure-all kind of thing. Some of my techniques work, some of my techniques may not work. Oh, sorry, not my technique, but Dr. Greenman's osteopathy techniques works. Some of it may not work for that particular patient. You have to know the tools of the trade in your arsenal, essentially. So like, for defense system, you have Army, Navy, Marine Corps, and, Air Force. So these are tools to defend yourself, right? To defend the country. So similarly, you have to know osteopathic technique. You have to know neurokinetic therapy. You have to know PDTRs. You have to know active release technique. So MFRs, METs, which kind of works and which may not work is a little bit variable. But to address your question in one answer, there is no one answer, unfortunately. You probably have to adjust the jaw, and the two techniques that I showed you are very, very to release medial pterygoids, and then also doing this one. This is not a manipulation per se. This is basically, we call it vector re-education. I don't think you've probably heard about it, but don't worry about it. So this is a very new recent type of treatment technique that's coming up. Not much research has done. So I use that, which is not high velocity. It's kind of a mobilization, functional mobilization type of technique that helps our jaw, that helps the TMJ to reset. What's next?
Sir, from Dr. Vaibhav. Hi, sir. There are any connections with the TMJ dysfunction with airway obstruction and sleep apnea and bruxism?
Bruxism, yes. Sleep apnea, I have not heard. Airway obstruction can be at different levels, so I cannot comment on that, because as you know, airway starts from here till it goes down. So obstruction where, I don't know from your question, so I should not be commenting on that. But in terms of the other two, bruxism for sure, yes. Sleep apnea, there is no evidence on that, and I have not seen that. But because I don't see any reason that sleep apnea should have a connection, but you never know. If there is never a yes and a no in a patient. You probably they might, but chances of having TMJ in sleep apnea is a rarity in my experience. Next
from I don't know the name, Galaxy J7 Prime. When percussion hammer gun is used for, or any other modality we can use in TMJ dysfunction? I think this already answered
the second question. Yeah, I addressed the second part of the question. The first part is percussion. When percussion hammer gun is used, usually during your trigger point. I use it during trigger point. So if there is any trigger, one point that is really painful and my thumb is not that hard enough to kind of break the adhesion scar tissues, then I use trigger point. Now, that's the reasoning. But when I do not use percussion hammer gun at the very first day, my osteopathic school of thought is you usually use modalities, if you call so, like these things, adjusters, in the middle part of the session, meaning after 1 or 2 sessions, then I can start using it so that the pain kind of subsides. I know the problem area. The patient has been coming with me twice, and the patient also trusts me, believes me. So the psychology of pain is extremely important. I need that trust to gain that trust from the patient. Once that a patient gives me that, obviously he or she will not say, I can feel that, then I probably will be using it. That's one of the side. There are many different variables and perspectives. You all know, you are all professionals, and when to do and what to do changes every time. All right.
Next from Padmashri Nath Bhumik. She's a final year BPT students. She asked contraindication for TMJ dysfunction treatment.
Contraindication, that's actually a good question. Unfortunately, in TMJ is such a joint that there is not much contraindication unless and until you have a new systemic, central nervous system neurological issues going on. Other than that, no. So we are essentially talking about pure musculoskeletal pain. If the patient walks into your clinic, and then I am pretty sure he or she is fine. So, but if the patient is not walking to you, if there are any neurological issues, then certainly you will not be able to give it. Makes sense? So, in essence, contraindications is for TMJ is very evident. I mean, you are not using per se any modalities like heat or cold, or I have never used tensor in the past 13, 14 years. All electrical instruments I have just not used, including ultrasound. In over a decade, I have not used, because in US it's hardly used. So to address your questions, contraindications, if you see a neurological problem, yes, it is, otherwise not. And if the patient walks to your clinic, no, it's not contraindicated. He or she is fine. Independently walking, I mean. All right. Next.
We are running out of time. The next question. Majid Barik.
No, adjuster.
I don't get the question.
Not in the same way.
Adjuster and guiding.
Yeah. So Dr. Barik, that's a great question. It is not in the same direction. The adjuster is little bit different because it is at an angle. It is hard for me to do a 3-dimensional thing here. It's all vectors, right? That goes on. So the adjuster is at an angle right over here, underneath, and sometimes at the posterior angle of the TMJ, close to the Eustachian canal. So the patient will be able to hear those clicks from the adjuster. Cut. And that would be painful if they have really super highly sensitive TMJ issues. That could be really painful. And if someone has ear infection with TMJ, adjuster will accentuate the pain also. But for the gliding technique, it's essentially a functional move, let's say, that is more inferior and medial, or inferomedially directed in this direction. Next. Other questions?
Next question. Is it always necessary to correct C1, C2 along with TMJ from Richa Kashyap?
Oh, Dr. Kashyap, how are you? Actually, Again, a good question. I do it C1, C2, even there is no pain in the neck. I do it. As I said, there is a I have found correlation between C1, C2 dysfunction and TMJ. So I have done that. I know many people, they do it. Most chiropractors do it. Not many osteopaths, they do it. But I have found good results. So I do it. I can say that.
Okay. Next question from Dr. Tapas Das. A patient facial palsy when mouth open extremely, after that he is unable to close the mouth or lock TMJ. What can I do on that case?
Just by one sentence, I cannot have an answer. I mean, it is impossible for me. And even if I say something, it is incorrect for you to know, that this, what I just said is like Vedvakya and you start doing it. That is not correct. So based on what you told me, I don't have a clue as to what the patient background is, medical history, other general history, other, tests and measures. So overall, if the patient is having any problem in the TMJ after facial palsy, let's say even after a year, you can certainly try and correct the TMJ, because TMJ is a joint issue. Facial palsy is a facial nerve issue. Now, that does not mean that the masseter or the temporalis will be a lax. It will be lax and it probably will be difficult, but you can find more control exercises in TMJ issues where the patient has or have had history of facial palsy, and try to do the best you can. But I have seen, I don't do it, I have seen and I have heard that acupuncture actually helps a lot. Like put the needles and then use a TENS machine and then kind of do some electrical stimulation in that. I have heard and seen that that works, but I personally don't do it. I don't have experience in that. Next question.
Next from Rakuda. This forum and disorder is palsy and facial palsy.
I mean, differential diagnosis, no. If you are saying TMJ like is present in bills or facial, I can understand that. They probably not. It is hard to predict. The individual who was sitting in front of you was my father, and he had facial paralysis 20. This is like 90% normal now, fortunately. And then he doesn't have any TMJ issues. Other than I did find a little bit of clicking on the left side, and probably I have to adjust him, but I don't think it's correlated because it's been 25 to 28 years already for him with left-sided facial paralysis and also clicking. Maybe long-standing chronic effect, but I don't see a no research.
Next. Okay. Next from Subradev, our final year student. Sir, TMJ is effective in case anterior open bite?
TMJ is effective in case anterior open bite. I'm not getting the
same here, sir.
The question.
From the next question from Tuhin Sinha, how functional taping is helpful to TMJ joint pathology?
Yeah, the people have done, but not much of effect in terms of functional. Initially in acute state, yes, to reduce pain. But again, if you tape it and the patient is eating or sleeping, then even if it's functional, as you said, it doesn't work that way. Because if you are taping in this direction and the patient is eating, then the vectors that's going in the other directions, that the tape will not help. So the tape can help in one vector, one area of pathology, not in the other areas of pathology, if you know what I mean. So
next
is yes and no.
Okay, next from Jaita Devnath. Sir, sometimes TMJ locked when opening in mouth and it's hard to close. Why it's happened? What is the treatment?
Yes, very good question, Dr. Devnath. So it happened because the disc is deranged, disc kind of slips back and it locks. So if you don't, the treatment is essentially you have to unlock the disc so that the jaw comes back. So there are the two adjusting treatment techniques that I did outside, one with the hand. There are other techniques also, it is impossible for me to show. So I use those techniques and the one with the adjuster to help the disc come back into place so that the jaw can close. But yes, it is possible, and the reason is disc is basically slips out of place, and you have to make the disc sit in place for the jaw to close completely normally. All right.
Next question from Anil Kumar, role of electrical stimulation and TENS in TMJ pain.
Probably I don't do it. I have never done it over 10 decades.
Already
I don't.
These things has been answered. Now I think all questions I have finished. Now from as an attendee, I have a question, sir.
Yes, Dr. Bhattacharya.
Yeah. What if I treat low back pain by treating TMJ dysfunction correction? So
you are going in a different direction. In NKT philosophy also there is a connection of muscle chain, and probably if you go through John Myers or Mayer's anatomy trains, he will also say that. I have not treated that chain or that link, so I can give you a personal view or experience, but I know for sure people do that. Not just TMJ, they also do sinus treatment, they do septal treatment, they do craniosacral therapy, also or cranial therapy to adjust the biorhythm of the craniocervical flow or cerebrospinal flow, and that's how they try to treat low back pain. I have not done it, but people do, so I don't have exposure in that. All right.
Okay, sir. Okay, sir. As we are going to wind up the session now, I would like to hand over to our state cell women's cell member, Dr. Sauli Sutradhar, to address vote of thanks.
Thank you so much, sir. It's my privilege to have been asked to propose a vote of thanks on our 10th webinar session of IP Tripura team. On behalf of the IP Tripura team, we are extending heartfelt vote of thanks to the respected resource person, Dr. Sanjay Sarkar sir, who gave us his valuable time from his busy schedule. A heartfelt thanks to you, sir, for your patience and time for all the participants. It was very informative, sir. Now we express our gratitude to IP technical team and IPCEC members, and especially we thank our president, Dr. Sanjeev Jha sir, and our treasurer, Dr. Ruchi Vashne ma'am, for giving us this platform for upgrading all the participants' knowledge. Thank you all. Now I hand over to the IP technical team. Thank you.
So thank you, sir. Thank you. Thank you.
Thank you. On behalf of IAP technical team, thank you so much, Dr. Sanjay sir, for the wonderful session. The way you explain about the TMJ joint, I hope every participant understand about the TMJ joint and its treatment principles, the joint adjustment. You explained very well, sir. Thank you so much, sir. I extended my thanks to Dr. Sanjeev Jha sir and IAP Treasurer Dr. Ruchi Vashne ma'am for giving all the participants such a great platform for the learning. I want to thank IAP Tripura State and Tripura Women's Cell team, Dr. Birbar sir, Dr. Devnath sir, and Dr. Soumya sir, Dr. Upanita ma'am, Dr. Shali ma'am for organizing such a great webinars. I request to all the participants, please like and subscribe IAP India YouTube channel and Facebook page for watching all the online webinars. Thank you so much, sir. Good night, everyone.
Thank you very much. Have a good night. Thanks. Bye. Good luck.